Hello and welcome to the Spinal Nerve Podcast. My name is Dr. Brian Helvis, and today I have the pleasure of being able to introduce you all to the newest member of our team here at Spinal Nerve, Dr. Jason Kung.
Hey, everybody.
Dr. Kung, welcome.
Thanks for having me, Brian.
Absolutely. And hopefully a voice that everybody's going to get to hear a whole lot more as things move forward here.
I've been known to be kind of soft-spoken, but I did pretty good in my public speaking class in college. So
we'll put you through the test, that's for sure. As you're coming in, I think the best way for everyone to get to know you is for us to really just kind of start at the beginning. Kind of tell us about where you grew up and kind of the kind of kid that you were.
All right. So fun fact, Canadian or previously Canadian. But yeah, I was born in Toronto. My parents immigrated there from China. So born in Canada on the East Coast, and spent some time there when I was up until about 5 years old, and then I moved to California, into the Bay Area. So really, I consider myself a California kid. Spent most of elementary school, middle school, high school there. Went to college in San Francisco, and then during that time was kind of my formative time. I didn't really, I wasn't born into family of doctors, or I didn't have this inherent drive to be a doctor when I was a little kid or anything. It kind of happened later on in life for me in college. So it was really during that time that I decided to go into medicine. That kind of was the start of me, in my early 20s, to kind of decide to go down that path. I don't know if you want to play by play exactly about what.
Well, I mean, do you remember like maybe an instance of, I think, Raman and I talked a little bit before, Dr. Gray and I talked before about, growing up playing sports, and, obviously a lot of us get interactions with doctors through that, sports injuries or something along those lines. Was there something along those lines that kind of lit the fuse or something like that?
Yeah, there's a few instances. When I was in college, I used to work part-time as a hotel doorman in San Francisco. So there would be a lot of conferences coming, and I'd see all these doctors come in. So, you're working as a doorman, you're kind of chit-chatting with folks, getting to know them, and you kind of talk to them. So I heard a lot about what people were doing and what conferences they were here for. So that kind of was one thing that kind of made me interested in medicine, because I knew I was interested in science already. I was majoring in biochemistry. So, but I liked talking with people. And I think, the fact that I worked as a doorman, talking to clients, kind of led me to try to find a career that would also involve me interacting with people on a fairly regular basis. Then in college, through different classes that I took, really took an interest in healthcare and in science. So that kind of pushed me towards it, eventually kind of leading me to go to the East Coast to do my medical training.
That's awesome. I don't know that I ever would have guessed that you would have been a doorman.
Yeah, it was an interesting time in my life. I had a really good time doing it. It was a really fun job. But yeah, I think my communication, interaction, patient or personal interaction skills have really stemmed from that.
Yeah.
So if you ever need a taxi, I can definitely hook you up.
I mean, if you think about it, a job like a doorman, where you have to interact with everybody that passes by, right, and be able to, be congenial and helpful, really does lend itself well to medicine. I mean, to life in general. But
yeah,
I know I had a attending before that said that everybody who goes into medicine should get a service job. In New York, he was referring mostly to people getting a job as like a waiter or waitress.
Right.
But something in that industry to be able to just learn how to interact with people, so that way you can have those conversations.
And I think it served me well, and I still use it. Every time I talk to a patient, I talk to you, I talk to everyone else. So.
Yeah.
But yeah, I mean, East Coast for a while, for about 10 years in Boston, and then I decided, hey, it's time to come home. Folks are getting older. Still a lot of friends and family in the area, so about 2 years ago, I moved back to the area.
So you kind of fast forwarded through Boston. What were you doing in Boston?
So I initially went to Boston to do a Master's of Arts in Medical Science program, kind of like a stepping stone towards medical school, kind of like proving yourself worthy that you're able to tough it out in the medical school classes. We're taking it with medical students. So I did that. I did that over at Boston University. Thankfully, they after I finished that program, they took me in for medical school. So that's where I did my 4 years of medical school at Boston University. And I had really no idea what I wanted to go into. At first, I think I wanted to be an orthopedic surgeon of some sort, and then I was dancing between emergency medicine. But then I ultimately decided on anesthesiology. It was something that was always known by me because during my time in medical school, I was actually pretty involved in this thing. It was a medical school band where basically a handful of attendings of various backgrounds, they're all different: ENT, neurosurgery, anesthesiology. But they all got together on the weekends to play music, and medical students would kind of pop in and fill different roles. Like, one medical student would be a singer, one would be a guitarist, bass player, etc. So I was a guitarist, and I was kind of involved in this multidisciplinary band situation. And basically, the attending there that kind of led the whole thing was an anesthesiologist, and I got to know him better, and he became my mentor of sorts, and that kind of led me into thinking about that as a field.
That's awesome. Tell me a little bit more about the band. I've heard rumors of this, but now that I have the ability to ask you about the band, like what do you play?
I play guitar. I play electric guitar.
And so you would just kind of fill in randomly whenever they needed another person to grab the axe and.
Yeah, I mean, I was kind of I was a pretty foundational guy. I was usually there on the weekend, so I was usually heading up the guitar rolls. The keyboardist was a neurosurgeon. There was another guitarist who was an ENT surgeon, and there was another bass player / drummer who was an anesthesiologist, and each of them had their own musical preferences and what they wanted to play. There was bickering. I mean, all in good fun, but just very similar to an operating room, except there's no drapes separating anesthesia and surgery. So, but it was all in good fun, and we kind of leaned upon the medical students that came in to be singers because we didn't have a full-time lead vocalist. So medical students would come in and they would be like, I want to sing this song. Then we would have to agree that we all have to play this song. Not begrudgingly, but we all put a little spin on it, and we were able to do a few performances around the school, and we even did a performance at the Berkeley School of Music.
That's kind of big time. Berkeley's kind of a big deal.
Yeah, we were not professional level at all, but we got to be on a stage and do all that at their kind of like student venue, music venue. So that was fun. But yeah, that was my kind of a lot of my free time was doing that, Friday nights or Saturdays and that kind of thing.
Nice. And so kind of got introduced to some mentors that kind of brought you into the anesthesia realm. And so obviously you went through the anesthesia residency and then decided to do pain medicine, which is kind of a little different than general anesthesia.
Yeah, very different. There are a lot of things that were similar. A lot of the procedures in terms of like various types of injections, whether it's a peripheral nerve block or epidural injections, were very similar. But obviously the difference is that, in anesthesiology, for the most part, your office is the operating room, right? Your break room is the operating room break room. You're intimately tied to the operating room environment with the surgeons, with the nurses there, and the patients that would come in and out for surgery. And I found myself over time, while I loved a lot of that aspect, I found myself looking to find a more deeper connection with the patients, some more longitudinal experiences with them, seeing, what I did for them. Did it work? Obviously, the result that we all wanted, but if it didn't work, to then troubleshoot about, what's the next step? What else can we try? And I was actually this close to going into pediatric anesthesia. But I kind of changed my mind at the last minute. It was really, distinctly remember when I was on my obstetrical anesthesiology rotation, where we placed lots of labor epidurals for moms, and we would do post-op checks too. So typically, if you're the anesthesiologist for a mom that's about to have a baby, you are the greatest person for a short period of time in that very intense emotional and physical time of their life. And I found that it was just so gratifying to see, the fruits of my labor, which was like an epidural placement, while kind of small on the scale of the whole scheme of having a child. It was really rewarding for me to see them in less pain, having to have a different labor experience, and then seeing them the days after, they were all still very grateful for everything. So that kind of pushed me to think about, hey, maybe I should try to find something that can let me still continue to do procedures and also see the results of my procedures. And if they helped, if they didn't help, what can we do better?
Yeah, it's super interesting. I've always wondered. I mean, obviously, I'm a physical medicine and rehab doc, and the previous docs that we've had talked to, through this process on this podcast have all been PM&R docs, and so I've always found it interesting because our training is longitudinal training from the very beginning, right? I mean, we're doing outpatient clinics from PGY 2 year, even inpatient rehab. You're seeing patients over a week to 2 or 3 weeks while they're there. So those longer term relationships are kind of just par for the course, or a part of our training process. And I always found it fascinating, particularly when I came into the field. I mean, anesthesia really predominated the field of pain medicine. I always thought it was very interesting because it is such a seeming departure from
Right.
From normal, or from kind of what people presume anesthesia is.
Mm-hmm. Yeah, it's definitely very different. You're either in the OR or you're not in the OR. And I kind of wanted, we're still in the operating rooms now when I do different types of procedures, but I definitely wanted that out of the OR experience, just to, have that relationship with folks. Before it was just meeting someone on the day of surgery. Sometimes it's an elective surgery and there's not much in terms of emotions with it, but sometimes it's a quite serious condition that they need urgent surgery for. So your interaction with the patient is very short. You have to basically establish rapport, and basically have them trust you with their lives for this intense period of time for surgery. So I really enjoyed that aspect of it, but I found myself wanting more. So that's kind of how I ended up here.
Well, since we haven't had the opportunity to kind of address this from the anesthesia resident perspective before, and what do you think are some of the big adjustments that say an anesthesia resident that's thinking about a pain medicine fellowship, or maybe entering a pain medicine fellowship, has to be aware of and prepared for, to kind of make sure that they're as successful as possible?
I think it's really I would say the patient interview, the history and physical. I mean, these are skills that we learn in medical school, and then when you go into anesthesiology, obviously we do a thorough history and physical that's applicable specifically to the type of anesthetic that we'll be considering for the type of surgery the patient is having. Versus in the office, you have, first off, you have more time to speak with the patient. And it's really kind of teasing out, what exactly is the patient experiencing. You see an MRI and there's 6 or 7 different pathologies on there. we're not robots. We have to figure out which one of those is causing the primary pain symptoms, which ones aren't, which ones maybe are, and really thinking about that, and then explaining to the patient, what the potential options are. So I think that part was kind of hard for me to learn and kind of refine. I'm still doing it now. So that's one thing. And then, the clinic, the pace of clinic is different than the pace in the OR. You have to, there's a lot of other things that happen when you're not actively seeing the patient. One thing that's different in anesthesiology is you meet the patients, you interview them, you examine them, you induce anesthesia, you maintain them on whatever anesthetic plan you have, and then after the procedure is over, that's most of the time it's the last time you see the patient, unless they have to come back for something else. But that's kind of the there's a beginning, middle, and the end, right? Versus in pain management, we know that there's rarely any procedure medication out there that can basically just completely eliminate the patient's pain. I mean, that doesn't exist yet, but it's management, right? And I think some of the other docs on the show have mentioned, it's just like diabetes management or any other management of chronic disease. You're not sometimes able to cure the disease, but you're able to just try to maintain it, improve function. So that's the other thing, is that you meet a patient, you may not be able to get an answer or the result that you want within a week, a month, several months. So having the patience and knowing that it may take a few times, a few visits to try to narrow down what's going on, having patience.
Yeah, no, I think that's a great way that you described it. I've had the pleasure of being able to work with a lot of fellows as they've been going through from across the country at different points through my career, and being able to kind of chat with them. And I think that patience thing is really really a very strong descriptor for the transition that that I've seen for for folks that come up through a training of anesthesia, right? I mean, there is no patience in anesthesia, right? I mean, it is about getting the job done, and it's there. Like you said, there's a beginning, there's a middle, there's an end, and it's very finite. And so being able to work with somebody over months or potentially years for some of these patients can definitely be a challenge, definitely changing of your perspective. And so as kind of working your way through your process, and so you've kind of find your way back over to California. Thankfully, we were lucky enough to have you come and join us. But now you're kind of out in the real world, outside of fellowship. You're now almost 2 years out of fellowship, and kind of really getting a hold on where things are in pain medicine. And what are the things that are currently exciting you, and that you're kind of looking to build on? And we've kind of talked about this from our practice perspective on how to really optimize your the things that you're interested in. But what are you thinking about these days?
I'm thinking about this. There's been this gap for a long time that's been there for many years before I even decided to go into medicine, where it's just injections, gap, then surgery, right? So that was if we did injections and it stopped working, then oftentimes, not all the times, but oftentimes the next step was to have a surgical intervention. And I'm excited now that the gap here is there's something else that's kind of coming up in between, and that something else is not just one thing. It's basically a multitude of various minimally invasive procedures, surgeries that I can now offer to patients that can potentially bridge the gap and either prevent them to need to have surgery in the future, or kind of delay the need to have any more invasive spine surgery in the future. And there's just so many procedures out there. It's really exciting to see all of them come out. It's been challenging to kind of see which ones are the ones that are really beneficial, which ones are the ones that, I don't really think that it's the right procedure for folks, but I'm excited and really doing all the things kind of to try to fill the gap in between. So, there's all sorts of things, obviously we've had spinal cord stimulation for many years now, but there's definitely advances in the ways that we're delivering the therapy. There's advances in the technology. There are other procedures that we can do to basically do nerve ablations in areas where we could never do it before. Various types of procedures to help people get relief from their spinal stenosis. So I'm excited for those. I know they're not, just like what I said in the beginning, there's not one thing that can eliminate the pain completely. I understand that they're exciting, and a lot of folks are really enthusiastic about it, but it's not going to be the thing that's going to eliminate people's pain. But if you can improve their pain enough so that they're able to interact with their family or work or whatever hobbies they enjoy, and able to do those things better with a procedure that's minimally invasive, kind of outpatient surgery, go home the same day kind of a thing, then I certainly am interested and excited to bring those to the practice.
Yeah, no, I mean, it is a phenomenal time to be in our field, right? I mean, I think, I got very blessed. I mean, I entered this field in 2015. It was kind of right after Nevro published their first paper that was, really I think a kick in the pants for the entire field, right? To really start looking at data, looking at ways of improving, something that had, for better or worse, just kind of slowly but steadily been progressing, and it really kind of lit a fuse under a lot of things. And so now we fast forward, now almost 8 years from that point, and the advances within neuromodulation have been astounding over that time. And like you brought up, we now have so many other procedures that are coming in, and probably most importantly, so much data that's being produced, right? I mean, I think for a very long time, one of the challenges with everything in pain medicine is that there was this very large lack of large data to be able to
right. And long-term efficacy data, right? So like anything beyond 12 months.
Yeah, and so now you're coming in, and you're talking about being able to working on spinal stenosis, or being able to burn nerves that weren't before, like the vasovertebral nerve ablation. I mean, these things are being brought to market where they already have 2-year data. Some of them already have 4 or 5-year data by the time that people are evaluating whether or not they want to utilize them for patients. That's pretty, it's a very fun time to be in our field.
Yeah, I think it's also a very, we have to be very mindful of kind of interpreting the data as well. I mean, I know you've already been doing that for your practice, but as someone that's, I don't know when the term new starts to fade. I mean, 2 years, is that still new out of practice? I still consider myself learning, so I'm still going to call it new, but still as someone there now that, there's no attending behind my back or in the back room waiting to hear my report and whether they're going to say yes or no, right? I mean, still, it's up to me. And, that's not always the case. We have these forums where we can talk, offline about patients, but, it's really up to you as the pain physician to kind of make that decision and try to, kind of rifle through all the different studies and the charts and the tables and the reports. It can be a little overwhelming. So definitely keep reading. Get a prescription, a subscription to whatever pain management publication that you read, and just keep reading, because there's always new stuff coming out.
Yeah, definitely. I think Nans describes the young physician as up to 5 years. So they keep the window, I think, fairly large. Understanding that, like you said, I mean, you're trying to get your feet under you. Obviously we all do plenty of things in fellowship, but to be able to be able to make those decisions and see those patients in follow up, to see what works in your hands, out in the real world, and how to
right.
make it. keep on evolving that. But yeah, I mean, continuing to, you know, to read and to find yourself a team of people that can, you know, hopefully help to push your education further and further, right? And it's always the goal of hopefully for all of us in medicine to keep getting better as we keep doing this.
Yeah, and it's good to have, you know, surround yourself with people that are better than you. Surround yourself with a good team. You know, we talk about, I guess I was talking about doing procedures to help folks, but you know, it's not always, it's not just me, right? There's the staff in the front, there's the people in procedure rooms helping with getting the patient through the procedure in a safe and in a safe manner. So I mean, you know, it's just surrounding yourself with a good team to get the patients the care they deserve.
I think that's a great way to say it. I'm gonna make a really hard left because at some point I wanted to fit this into the conversation and I didn't know how to, and there's no real good transition for it. But you know, one of the things that I know Dr. Gray has brought up many times when talking to you is that you are a very fit young man. Part of I think the envy is that both Dr. Gray and I are getting old and we don't quite feel as fit as we did when we were your age. But
different in age, but okay, yeah, go ahead.
But so talk to me a little bit about what health and wellness and all of that means to you now as an attending physician, because obviously it's an important part of your world because you live it. It's an important part of being able to treat our patients. But like how does it, you know, just live at that? How does, you know, health and wellness kind of fit into where you are at this point in life?
Yeah, I mean, thank you, Dr. Garai, if you're out there. But it's a big part of my day-to-day. I mean, I think, you know, the mind body, obviously we know that they're connected, and if one takes a nosedive, the other one will usually follow suit. So, you know, it's definitely more challenging to get in physical exercise when you're an attending. You know, you don't have quite the flexibility that you have in fellowship. Not every fellowship is different, but typically you have more flexibility in time and responsibilities. So you have to kind of carve it out and ensure that, you know, you're still able to work on your own physical and mental health outside of work, so that when you're at work, you're at your best, right? So I try to work it in, you know, 3-4 times a week. Thankfully, my wife is also into it, so we use that as kind of our quality time. So I have found myself kind of changing the way that I exercise my body. I think that's one, because of COVID, with everything locked down a few years ago, that was, you know, a hard left to make me change my ways that way. But then the other one is just, you know, from seeing so many patients that are coming into me with chronic pain of various types. I've found more that's exercise that involves more stability, endurance, versus kind of the more aggressive things I was doing in the past. I found that to be kind of better for my mental health as well as my physical health. So then obviously, you know, at work, I would say my job now, oh, this is another thing that's different between anesthesia and interventional pain. I would say that in anesthesiology, you know, you're actually physically, you're moving around a lot. I mean, you know, it's the analogy of the airplane pilot that's been used over and over again. I'm going to say it anyways. You know, it's, as my attending would say before, seconds of terror followed by sometimes hours of boredom. So, you know, the flight taking off, you're inducing the patient, and then that's pretty stressful. And then once everything calms down, it's a little less stressful, but it's still mentally stressful. But you know, during that time, you're walking to and from the preoperative area, you're walking around the operating room, you're bending down, you're standing up, you're twisting around. So when you're doing interventional pain, you know, obviously when you're doing injections, you're still walking around, moving around, but you're not walking nearly as much as you would be doing anesthesia. And then when in clinic is clinic. So I found that, now that I switched over to more of a clinic-based and sometimes procedural, my I'm not moving around as much at work. So I've actually had to increase my after work physical activities to try to make up for it.
So you're saying we need to move your office further away so you can get more steps in during the daytime?
I take the long way to the front, actually.
Well, we're working on a new building, so hopefully it will have more space for you to be able to get your laps in.
Good.
All right. Well, I appreciate this. I feel like I got to know you a lot better. I think it's been a fun time to kind of get to know you a little bit deeper. And, I'm hopeful that our audience is going to be looking forward to kind of hearing from you more often. I know we're going to start working on ways to, start re-up the education and working on everything from journal clubs to some kind of further deep dives into some of the more relevant topics of modern pain medicine. But
that'll be fun.
What parting thoughts do you have for our people that have made it 35 minutes into our recording today?
Parting thoughts. If it's I would say patience. If you like procedures, you like seeing patients, and you like figuring out a puzzle, then interventional pain management might be for you.
I love it. All right, guys, thanks for listening. Everybody send a love note to Dr. Kung. He will be officially on LinkedIn for people to reach out to him at some point in the not too distant future once we get his fancy new headshots in. Otherwise, stay tuned for those legal disclaimers, and we will talk to you guys next time.